Good afternoon, dear colleagues, dear chairman, honest tennis players community. I am glad to be here and thank for your invitation and the opportunity to give my presentation about exercise prescription, long-term physical activity, and cardiovascular diseases. In Lithuania, life expectancy at birth and at age 65 is likely to be one of the shortest in European Union. For example, the life expectancy of men is only 68.5 years and had increased only by 2 years over the last decade, while the biggest changes have taken place in Estonia, 72.5. Fortunately, female life expectancy in Lithuania doesn't differ much from the rest European Union countries. Another big challenge is the aging of Lithuanian population. Approximately 20% of the population is over 65 years old. Regarding to the comorbidities and age-related change in physiological status, the rehabilitation process and long-term physical activity becomes complicated. Outcomes of cardiovascular diseases are very relevant for all European Union. In our country, every year, 57% of all deaths are due to cardiovascular diseases. Disability-adjusted life years are key measure of population health that compare mortality and morbidity. Dailies of cardiovascular disease in Lithuania is the biggest and growing comparing to the other countries, for example, same Estonia. Speaking about cardiovascular disease, for example, one of them, heart failure is a major and growing public health problem. Thinking that about 2% of the population in Europe have heart failure. As many as 1 of 5 people aged from 70 to 80 years have heart failure. We calculate that prevalence of heart failure syndrome is under 3% in all Lithuanian population. The main causes are increasing prevalence of cardiovascular disease factors, aging population, and improved post-myocardial infarction survival of patients. In Lithuania, after coronary events and revascularization procedures, 94% of patients are recommended follow-up cardiac rehabilitation, and 90% of which actually attend the program. Government covers the cost of 18 beds a day for acute myocardial infarction and, for example, 24 bed days for stroke rehabilitation phase 2. Average daily cost is for just 48 euros. Comparing the average attendance to cardiac rehabilitation program in European Union countries is just approximately 45%. For example, in Germany, only 50% patients after heart transplantation are offered fully covered cardiac rehabilitation. Perhaps it depends on insurance, economic status of the country, etc. Speaking about cardiac rehabilitation programs, the main question is what are the core components of cardiac rehabilitation? Firstly, when patients arrive into cardiac rehabilitation hospital after assessment, exercise capacity and ischemic threshold evaluation and physical activity counseling exercise training program is essential. Usually for the ischemic patient, we prescribe aerobic exercise training, and all patients are divided into 3 risk groups: low, moderate, and high-risk patient. For example, for low-risk patient, at least 3 sessions of from 30 to 60 minutes week aerobic exercise of 55 of the maximum workload are recommended. For moderate and to high-risk patients, similar to low-risk group, but starting with less than 50% maximum workload, and adding resistance exercise. The metabolic equivalent task can be the gold standard for defining physical activity intensity and energy consumption. And 1 MET equals to the energy burned at rest, which is up to 38 calories for every 30 minutes. All physical activity can be divided into low, medium, and intensity. Currently, when you sit, you burn about 1 MET. Low intensity level, for example, require of the 840 kilocalories per hour, and in high intensity level require plus 25 METs. Different physical activities and workouts require different amounts of energy. For example, Pilates class require up to 3.5 METs, walking very briskly up to 5 METs, swimming crawl up to 8, and running at morning up to 11 METs. I have question for the audience. What do you think about the level of physical intensity when we play tennis? It is low, medium, or high intensity? Mr. Sherman? It's a light or hard activity? Hard activity. And how many METs do you need when you start to play tennis? Approximately. I think from 11. In process of physical activity counseling, various parameters can be used. In our hospital, we use peak VO2 value, which I see in peak equation depends on lung, heart, and leg muscle function. During the rehabilitation process, we can improve the muscle activity and the maximum oxygen uptake. Exercise training increase VO2 max, improve lipid profile and endothelial function, increase abundance of capillaries, mitochondria, and metabolic enzymes in different organs and systems. I will remind you that 1 MET is equal to 3.5 milliliters per kilo per minute VO2 max. And in our rehabilitation hospital, we do cardiopulmonary exercise testing for all patients after coronary intervention procedures or coronary artery bypass surgery. I would like to show example of CXT. It's patient, 57 years old, 8 days after valve heart surgery. And unfortunately, in this case, CXT was cancelled because paroxysmal atrial fibrillation complication occurred during the test. In a few minutes, sinus rhythm was restored. And how to interpret CXT data? For example, we performed CXT for 52 years old patients 3 weeks after acute coronary syndrome with reduced left ventricular ejection fraction. Usually for the healthy 52 years old patient, prediction value of workload is 181 watts and peak VO2 peak VO2 is 23.7. But for our patient after acute coronary syndrome with reduced left ejection fraction, peak VO2 was just 11.8 and workload just 132 watts. I will remember you that if you have patient with chronic heart failure, indication for heart transplantation is value of peak VO2 is about 10-11 milliliters per minute per kilo. Of course, in everyday clinical practice, we can use sample tools. For example, a 6-minute walk test with an estimated value of 300 meters or more. In other words, if the patient walks this distance, the clinical outcomes are better compared to less than 300 meters. Excuse. Also, the most important are the following core components of cardiac rehabilitation: diet, nutritional counseling, weight control, management of major cardiovascular risk factor, blood pressure, lipid control, smoking cessation, and psychosocial management. Very often, cardiac, cerebrovascular, and peripheral arterial disease is linked to clinical depression. Recently published data shows that about 20% had a history of depression. And after adjustment for cardiovascular risk factors, history of depression was associated with stable and unstable angina, myocardial infarction, heart failure, ischemic stroke, intracerebral hemorrhage. Therefore, the role of psychologists in the rehabilitation team is very important. Do we know everything about physical activity? There is clear and undoubted impact of genetics and epigenetics on both sport performance and exercise adaptation. 47% of the variance of VO2 max response is determined by irritability. And in the heritage study published 20 years ago, scientists conclude that familial aggregation of VO2 response to exercise variability is equal to 47%. Circulating microRNAs as potential biomarkers of aerobic exercise capacity. MicroRNA are crucial intracellular mediators of various biological processes, also affecting the cardiovascular system. I will remind you that microRNAs comprise a class of 20 to 25 nucleotides, modulate gene expression, and plays important role of wide range physiological and pathological processes. I will remind you that treatment of hepatitis C virus becomes successful after specific microRNA identification. And for example, we have specific microRNA for cardiovascular system, microRNA 1, 133A, 206, 208B, and 499. For example, microRNA 1, 133, 206 correlated to aerobic performance parameters such as maximum oxygen uptake and running speed. While these microRNAs are highly abundant in both the skeletal muscle and the heart. And for example, microRNA 208 is more specific to myocardial tissue. For example, immediately after finish of the marathon to next 24 hours, a significant decrease all specific microRNAs. MicroRNAs 1, 206, 133 was observed. And after next 24 hours, as biomarkers return to beginning level. It is believed that up to 20% patients are non-responding to sport or exercise performance. And the effects of exercise or physical therapy are effective when applied. And it is important to emphasize that physical training is a safe therapeutical tool. Let's come back to cardiac rehabilitation program and the principle. In clinical practice, we use FIT method for describe exercise training characteristic. It is frequency, intensity, time, type, and mode of training. Frequency, it is how many sessions we completed per week. Traditionally, now in our rehabilitation setting, at minimum, it is 6 sessions per week. Intensity can be measured by VO2, VO2 max, heart rate reserve, or percent of heart rate. Time, usually duration of the session is up to 45 minutes per day. And speaking of the training type, it depends from the physiological status and the disease of patient, and patient is prescribed on the following training types. It's aerobic training, endurance, resistance, or combined exercise. Very often, the essential question is what type of training is effective for cardiac patient. In a meta-analysis published 5 years ago, different types and modes and training were compared. Researchers found out that combined type and isotonic mode of training had better outcomes. For example, in our hospital, combined time in training usually makes 70% of aerobic training and from 20 to 30% of endurance type of training. I would like to show an example of exercise training. In a 6 years ago published article, researchers claim that one of the muscles, for example, quadriceps strength, is a good predictor of exercise capacity in coronary artery disease patient. Authors conclude that decreased quadriceps strength is linked to all-cause mortality. So, exercise strongly correlates with patient survival. Higher physical activity corresponds to a better clinical outcomes. Naturally, we think, what level of strength does my patient require? If quadriceps strength corresponds to 50% of body weight, it is equal approximately 5 mets. For example, I believe that tennis players' quadriceps strength correspond to 60% of body weight and is equal more than 11 mets. And on the other hand, decreased quadriceps strength signals about higher mortality risk. One of the example could be frailty. One of the example could be frailty, which are very relevant in clinical practice nowadays, especially speaking about patient plus 65 years old. What is definition of frailty? Frailty is a progressive age-related decline in physiological system that result in decreased reserve capacity, which confer extreme vulnerability to stressors and increases the risk of the range of adverse health outcomes. In our hospital, in our rehabilitation hospital, we evaluate approximately 160 patients, age 65 and older, and we found out that 27% had the frailty syndrome. We have big challenge for this patient. Intensity of aerobic training depends on the disease. For example, for patient with stable or chronic angina, we prescribe aerobic exercise intensity from light to severe. For patient after pacemaker or cardiodefibrillator implantation, we prescribe from light to high. Every year, European Society of Cardiology publish approximately 56 guidelines on diagnosis and treatment of different diseases and syndromes. Over the last 2 years, they published 9 guidelines of arterial hypertension, syncope, myocardial revascularization, cardiovascular disease during pregnancy, valvular heart disease, peripheral arterial disease, and acute myocardial infarction, all of which had major chapters for rehabilitation treatments. Let's talk about guidelines of arterial fibrillation. For example, long-term physical activity and exercise time is strongly decreases dyspnea and improves clinical status. A study with chronic atrial fibrillation patients who had 2 months or 24 sessions physical activity program demonstrate that long-term physical activity improved quality of life. After 24 sessions, patients find it easier climb stairs, carry grocery, use a bathroom, and other daily activities. It's the same situation speaking about patient with peripheral artery disease. And patient after 6 months after surgery in the rehabilitation group has significantly improved physical function, general health, social function comparing to the control group. In the beginning of the presentation, we spoke about heart failure importance for public health. In the 2016 ESC guidelines for heart failure, long-term physical activity plays a huge role. It's recommended that regular aerobic exercises encourage in patients with heart failure to improve functional capacity and symptoms. It's recommended that regular aerobic exercises encourage in stable patients to reduce the risk of heart failure hospitalization. That both recommendations are one level of evidence. Same recommendations are also found in 2015 American Heart Association guidelines for heart failure. Contrary to the heart failure reduced ejection fraction, in clinical practice treating heart failure with preserved ejection fraction, it is a challenge because it is non-responsive to medical treatment, including innovative drugs and device therapy. But only long-term physical activity is effective for both syndrome treatments. Similar to heart failure guidelines for patients after acute ischemic syndrome, structured rehabilitation programs are recommended. It has been proven rehabilitation program to be as effective as medical therapy. It's the same one level of evidence. Participation in a cardiac rehabilitation program for this patient is recommended. It has been proven that long-term physical activity reduces concentration of biomarkers. For example, for chronic atrial fibrillation patients, after 3 months concentration of NT-proBNP, BNP peptides was significantly reduced reduced, and norepinephrine concentration was significantly reduced for ischemic patients, while workload and peak VO2 significantly increased. In conclusion, while treating heart failure, ischemic syndrome, long-term physical activity is equal to medical treatment, and the level of evidence is the same. Long-term physical activity, beta blockers, AC inhibitors are crucial to the patient's survival. And speaking about safety of long-term physical activity, it is natural to wonder if long-term physical activity is safe for cardiac patients. Interestingly, data from your observational research pilot survey on atrial fibrillation general registry demonstrates that patients with intense or regular physical activity had better survival rate than patients without or occasional physical activity during 1 year. And can tennis help you live longer? Tennis, compared to sedentary lifestyle, add additional 90 years to person life. Badminton comes as second, adding 6.2 years. And comparing to the health club activities, just approximately 2 years. We are often asked if physical activity could provoke paroxysmal atrial fibrillation. Guidelines emphasize that it is quite the contrary. Low or moderate physical intensity prevents paroxysmal atrial fibrillation. And similar questions arise speaking about patients after acute coronary syndrome, myocardial infarction. I want to emphasize that all physical activity less than 2.2 meds are safe to this patient, and just the workload above 7.2 can increase the chance of new attack of heart or acute coronary syndrome by 2.6 times. And take-home message about the benefit of tennis for cardiovascular system. Thank you very much.
Thank you. Okay, do we have questions from the audience concerning the physical activity, cardiovascular diseases, the prevention?
Let's go.
I have one question. Yes, about the last thing you have showed about the tennis. How we can monitor the physical load to your heart during the physical load or during the play? What is your advice? For example, if we have the person which is having higher risk of cardiovascular diseases, and it should be monitored for the heart rate limits and so on, what you should advise how to do it safely?
Speaking about tennis it is moderate or very high physical activity, and for patient after, for example, a myocardial infarction, we don't recommend it. And maybe after 6 months, we can clinical evaluate and prescribe physical activity.
Okay, so if
But
the,
yes,
so I'm asking if the patient is already is okay.
yes, it's
So
okay. We can use for example, I use the smartwatch. It's as a possibility. It's
just to
medical
monitor
devices.
the
Yeah,
heart
just
rate
monitoring. Yes,
and play according your limits
yes,
of the heart
yes.
capacity.
That's a good choice.
Okay, thank you very much.
Thank you.